Hi, everyone. Welcome. We're just going to give it another minute or two and let people trickle on in, and then we'll go ahead and get started. All right, we can go ahead and get started. Hi, everyone. Thank you for joining us today for the evolution of the Massachusetts SANE program. My name is Brenna Chase. I'm the Director of Communications and Training at MOVA, and I'm just going to run through some really brief logistics before I pass it off to our presenters today. First and foremost, this is a Zoom webinar, which means that you as the audience cannot be seen or heard, but you should be able to see the presentation as well as the presenters and the ASL interpreters. There will be time at the very end of this presentation for questions. So as those questions come up, please feel free to use that Q&A function down at the bottom of the screen. Drop your questions in there and we will get to them at the end. We have both ASL interpretation and CART captioning available for today's session. To view those closed captions, you can go down to the very bottom of your screen and click on the closed caption icon. And then you should get prompted by the little arrow in the top right to select show subtitle. And at that time, you'll be able to view those captions. If at any point you're having issues trying to get those to show up or viewing the ASL interpreters, or really any other tech issues of any sort, please feel free to use that chat function to chat myself or my colleague, Charlotte Hoff, and we will do our best to assist you. Following today's session, we will provide a feedback link. I believe Charlotte likely already dropped that in the chat. We do ask that you complete that. We really appreciate your feedback, and we use your feedback to improve all of our future trainings and events. With that, I'll move forth with introducing our presenters today. I'm going to start with Christy. Christy Holden is the Associate Director of the Massachusetts Adolescent SANE Program. Christy is responsible for statewide service delivery to patients 12 years old and up in 40 hospitals across the Commonwealth. Catherine Bowles-Dudich is the Associate Director of the Massachusetts Pediatric SANE Program and is responsible for program management. She's the direct supervisor of the 8 pediatric SANEs who work in children's advocacy centers across the Commonwealth. And last but certainly not least, we have Randy Petriconi with us. Randy's the Associate Director of the Massachusetts Department of Public Health's National Telenursing Center. He is responsible for ensuring quality care is provided by contracted TeleSANEs to patients seeking post-sexual assault care at remote TeleSANE hospitals across Massachusetts. Thank you three for being here with us today. With that, I will pass it off to you all.
Thanks, Brenna. So I'm going to start and talk about the adolescent adult arm of our program. And first and foremost, I'm just going to give you a trigger warning. Today's training can be very sensitive, so please take care of yourself. I know you're all off camera, but mute if you need to, or unmute if you need to talk. Leave the room, get some water, breathe, all those good things. We'd like to start with this pretty daunting statistic. Every 98 seconds, a person in the United States is sexually assaulted. So we're going to talk about the care that those patients are going to get. These are our objectives for today. We want to give you an overview of the 3 arms of our program. We're going to review the components and how the service deliveries is done in each arm. And we're going to highlight some of the program's innovations during our COVID pandemic. So first and foremost, the mission for our program is the delivery of coordinated, compassionate, comprehensive, expert forensic nursing care to sexual assault patients across the lifespan. This has been our mission since the beginning of the program 25 years ago. So why SANE? Before the inception of SANE, sexual assault patients would experience very long waits in the emergency department. I know this because I was an ER nurse back then, working in a level 1 trauma center in Boston. It wasn't for lack of compassion for them, those patients that presented to our hospitals, but it was more like a game of catching the hot potato. Nobody was really comfortable doing the exam. No one wanted to mess it up. I'm not sure what mess it up meant, but we didn't want to mess it up. Patients waited hours in a busy emergency room waiting rooms. Evidence wasn't collected properly. We didn't know the proper technique. The chain of evidence wasn't maintained. I can remember doing a case in the emergency department and walking around with the kit under my arm until police showed up to take it from me. And last, we were really not trauma informed, nor were we victim centered. So with the inception of the SANE program came the unfunded mandate from the then Governor Weld. So rumor has it, but I believe it to be true because I heard it back in 1995, that the governor read an article on a plane about the Tulsa, Oklahoma SANE program. And the idea was formed to bring this to Massachusetts. The first training started in September of that year, and I was a participant in that class. So 1997 was the year of the initial funding for the program, and it prompted the 4 locations in Boston and Lawrence. Catherine will speak about the expansion to the pediatric population, and Randy will discuss the most recent arm of the program with the National TeleNursing Grant in 2012. This is what our program looks like on the map of the Commonwealth right now. And as you can see, we are in 40 hospitals. 30 of them are in person, which is the 10 purple circles. And I mean, the 30 purple circles, 10 are TeleSANE designated sites. Those are the green squares. And the triangles represent the pediatric SANE locations, the CAC locations. I love this slide because it really depicts the core of our work and what is truly at the center. And as you can see, the patient is at the center. And right to the right of the patient is the trauma-informed best practices circle. That's really, the core of how we want to take care of these patients. So we respond that way with a patient-centered trauma-informed practice and interface with all these multidisciplinary team members to best meet the needs of the patients that we serve. And all these needs are unique to each patient. We have formed many strong relationships with these team members over the years, and our circle expands and evolves as we seek to provide the best care to our patients. Per SANE statute, we have a working advisory board. So these organizations that are listed are all the required members of the board. The board advises the program on policies and procedures. There are also other agencies that sit on the board that are not listed that also help to advise our program. As you can see, MOVA is listed here. So I'm going to try to give you a little picture about what the in-person adolescent adult SANE program looks like. We do respond to 24/7 to 30 of the Massachusetts designated SANE sites. We have a memorandum of understanding from DPH to the hospitals so that we can go in and respond to the patients that are there. The response is organized into 6 regions, and I'll show you the 6 regions. Each region there's a regional coordinator who oversees the service in that region. They oversee the staff and scheduling and trainings and outreach. We have about 170 or so on-call SANEs that are consultants for the Department of Public Health that work with us. I'll talk a little bit about the SANEs in the Northeast and Cape region as well. The MA SANE role. So what is the role of a SANE nurse when they respond to the hospitals? So when a patient presents to the designated SANE site, the patient is medically cleared by a clinician in the emergency department. And once they're medically cleared, a page will go out to the SANE who will respond to do this really kind of comprehensive head to toe exam. That exam and interview of the patient, and the collection of the evidence collection with utilizing the sexual assault kit. We're going to do forensic photography if it's indicated. We're going to document the account about what happened to that patient. We're going to maintain the chain of custody. When the SANE starts to do the exam, they never leave the room. So chain of custody is always maintained. Plus, we're going to consult with the ED staff to make sure that the recommended medications for prophylaxis are given and follow-up care is provided. We work collaboratively with rape crisis advocates who come into the room to make and work with us to make sure that the patient has counseling in the emergency department, but also a place to follow up. We're going to consult with police if the patient consents, and maybe speak with the police after if the crime has been reported. We're also going to complete all mandatory reporting forms. So these are some of our patients. Catherine will speak to the SANE care for the children, but in Northeast and the Cape regions, those SANE nurses are cross-trained to collect evidence on children that present to the emergency department, the children that are 11 and under. Our overarching principle for all of our patients is a do no harm. So nothing we do is going to cause the patient harm. Many of our SANE designated hospitals have the MOUs with correctional facilities, and those patients that present to the emergency room are going to get rape crisis advocates to come to the hospital and a SANE nurse to come to the hospital to provide that care. The next couple of slides are our designated in-person SANE sites by region. And as you can see, Boston region there's 7 hospitals, and that is our busiest region. Western Mass has 6 hospitals there. That is a very large geographic area that those SANE nurses cover. Southeast, also has 7 nurses, 7 SANE sites, 7 SANE hospitals, and those nurses cover a very large geographic area as well. Central Mass, they cover Harrington Hospital, Milford, and then the hospitals in Worcester. Northeast and Cape, which are the ones that take care of the pediatric population as well. So all ages of people that present to the emergency room for sexual assaults will receive an in-person SANE exam and kit if needed. And those are the hospitals that those 2 regions cover. This is a graph that just depicts the service delivery for the past few years for the adolescent, adult, and the pediatric patients. And as you can see, we see well over 1,000 patients each year. This fiscal year, we will have a number over 1,000. With COVID, our numbers definitely change, which I will talk about. One thing that we like to bring up is the point of entry for EMS services. This is a statute that outlines how EMS providers can bypass one hospital and go to another. This can be done by patient request, or if an EMS is transporting a sexual assault patient, they can bypass a non-SANE hospital and bring the patient to a SANE site. And this is because they are getting a higher level of care. So I think an example would be if a patient was, say, assaulted in Milton, EMS could bypass BI Deaconess Milton because they do not have SANE services in that hospital. They could head north and go to BMC, or they could head south and go to Good Samaritan. It's an in-person, or Brockton. Good Samaritan is a TeleSANE hospital, or Brockton, which is a in-person. So what's the purpose of our SANE exam? So of course, a goal of evidence is maybe the recovery of DNA from the assailant. But what the SANE does is a lot. We do an interview which documents the history about what happened during the assault. The history about what happened will guide the steps of the evidence collection that we do. So we're going to do that comprehensive head-to-toe exam, looking for any injuries, identifying any assault-related injuries, and documenting any injuries, maybe taking pictures of those injuries, and looking for trace DNA that may corroborate what the patient has reported. Another goal is to provide the patient with some control. So I think the patients that we see in the emergency department have come to us after a trauma, all of them, a place where they've had little to no control over a situation. And we are going to give them back some control and hopefully empower them in the process. The time frame for our evidence collection, how long do we have? So if a patient is 12 and older, we have up to 5 days or 120 hours. Doesn't matter if the patient has showered, doesn't matter if the patient does not remember anything. If a patient presents to the hospital, doesn't remember what happened, but there's a concern that there was a sexual assault, we're going to do all steps of the kit. If a patient is 11 years and younger, they're considered a pediatric patient, and evidence can be collected up to 3 days or 72 hours. I have been in a room with a patient and we've kind of done the time frame, and it's been 119 hours and 30 minutes, and we've started the kit. This is what the outside of our box looks like. And the picture to the right is actually the kit that is spread out on 2 different side tables. You can see that it takes up a lot of room. So we need a lot of space in those in the emergency department rooms. So the collection of the kit, so our sexual assault evidence collection kit, has 16 steps. And like I said, it is guided by the history of the patient, if they remember what happened or anything. The average time that this takes in the emergency room is 3 to 5 hours. The patient, like I said, definitely controls the pace of the exam. Our Form 1 is a consent form, and that's the first thing that we do is get consent from the patient, and we ask to do all of, we're going to collect this, we're going to do this, and if during the exam the patient needs a break, they get a break. If they say, you know what, I just can't tolerate this part of the exam, they don't need to do that part of the exam, and it's just the patient declines. So they are really in control of this, and we're really trying to meet their needs and empower them. The kits themselves, if the crime is not reported, the kit is not processed. So, we'll tell the patient that we're gonna keep this kit for 15 years. You have 15 years to decide if you want to report this crime or not. If the crime is reported to the police, the kit will be transported to the crime lab and it will be analyzed by the crime lab. If the patient is 15 years or younger, all of those kits get processed. And we'll tell the adolescent that in the emergency room. If they haven't reported this to the police, their kit is going to be processed. And what is track kit? So Governor Baker signed this track kit bill into law back in, I think, 2019. It's been, the web base has been out. The hospitals have been doing this since last year. It is a web-based system that allows the patient to track where their kit is located. So once the kit is completed in the emergency room, the hospital staff will enter that number. You can see that's an MA number with a barcode. So they'll either scan the barcode or they'll enter that into the track kit system, and it will pop up questions to be answered. Who collected the kit? So the nurse, if it's a non-SANE site, or the SANE nurse's name will go in there. We'll enter if the patient is under the age of 16. We'll answer that question. If a tox kit was done, we will enter that question, and that tox kit number will also be entered into the track kit system. And the city or town where the assault occurred will be entered. Once the city or town gets entered, it will do a notification to that city or town that there's a kit in the emergency room to pick up. So it just keep people informed, like the medical facility staff know that the kit has been entered and where the kit has gone. Law enforcement officers will come and take it from the hospital. They'll do their part of entering it into the system, and then either bringing it to the storage facility if it's not reported, or to the crime lab if it is. Prosecuting attorneys have access to this kit track system too, and lab staff. But most importantly, the patient has access to this information. So we'll give them, and it's a little card. We'll give them this little card that comes in the back of the kit, and it's just the web page that they can actually log into. Their user number is their kit number, and their password is on that card. First time that they log into the system, they'll change their password. They'll change their password and answer some questions. So it's unique to them. So what happened during COVID? So as you can imagine, I also work in an emergency room per diem, and our numbers of patients presenting to the emergency departments plummeted. Dramatic decrease in all of emergency departments across the Commonwealth. We also saw a decrease in SANE patient volume. So the SANEs continued their in-person. So we went into the hospitals when a patient presented for a sexual assault. We went in full PPE and took care of the patients. You know that I told you that the exam takes 4 to 6 hours, and being in a closed room, very close to a patient, one-on-one and not 6 feet apart. So we had a modified COVID protocol that we did with the SANEs, try to minimize the time with the patient. Some things we did outside the room with setting everything up. Inside the room with the evidence, the nurse would take the evidence outside the room to repackage or go into a different room alone. We did a little modified exam too, but we were also worried about those patients that would not go to the ER, that were afraid to respond. So what we did pretty quickly is we kind of opened these pilot clinics. So Health Imperatives in Brockton and Plymouth said, yep, we'll let these patients come in. So we got everything together to have patients respond to the clinics at Health Imperatives in those 2 locations in the Southeast, and a location in Worcester at the Edward M. Kennedy Health Center. So we also had we targeted TeleSANE capacity too, but I'm going to let Randy discuss what we did on the telehealth side in one of our regions. So that is the adolescent adult program in a quick nutshell. I'm happy to take questions at the end for this, but I am going to pass this over to my colleague, Catherine Judich.
Catherine, I think you're on mute.
Sorry about that. I'm Catherine Bowles-Dudich. I am the Associate Director for the Pediatric component of the program. So people refer to our staff of nurse practitioners as PD SANEs, and they are located in 8 of the 12 children's advocacy centers across the Commonwealth. They're part of a multidisciplinary team response for reports of disclosures or concerns for child sexual abuse. And they do deliver excellent health care, which is really focused on the child's health and well-being. And we refer to them as patients rather than victims in order to ensure health, well-being, and recovery. The exams that are done on children 11 and younger are non-traumatic and non-invasive. The PD SANEs also can provide sexual transmitted infection testing. They provide a lot of information and education to the patients, the non-offending guardian, and linkages to primary care providers in the community, as well as ongoing education and updates to the other members of the multidisciplinary team. In addition, the PD SANEs are frequently called on to act as a fact and or expert witness for trials. And you probably already understand that very, very few cases actually end up in a trial setting. There are plea bargains that can happen, and many times there may be a decision for one reason or another not to charge the offender. Okay, next slide, please. The TeleSANE role is really comprehensive. In a CAC setting, what tends to happen is that when we receive, the CAC is a closed system, let me say. The only way that a child would come to a CAC would be either through a police report or a report called a 51A from the Department of Children and Families, where a healthcare or other provider, someone who has eyes on children and is mandated by law to report, files one of those reports with the Department of Children and Families. The CAC, when it receives those sort of reports, will bring the child and the non-offending parent or guardian in for a forensic interview. What happens during this forensic interview is that the child will sit with a specially trained interviewer who is educated in how to elicit a story from the child about what happened to them without asking leading questions in order to preserve that interview for future use if a case does go to trial. So they're in a room, a small room at the CAC, which has cameras and microphone, and the multidisciplinary team members sit in another room to view that interview and are able to ask questions, ask the interviewer to pose questions if there are some concerns, something that hasn't been addressed yet. They participate in pre and post team meetings when forensic interviews take place. And most importantly, they perform a forensic medical exam, which includes a head to toe assessment with some photo documentation and examination of the child's external genitals. The purpose of all of this really, and the child will leave with a sense that their body is healthy. Okay, thanks. Next one. So the nature of child sexual abuse is really very different from that of the adolescent adult experience. We see very few acute cases, especially at the CAC, mainly because the business hours sort of preclude that. But overall, the majority of the cases and the patients that we see have been subjected to chronic sexual abuse, taking place over sometimes weeks, months, and years, before the child finally feels safe enough or with a person where they feel they can disclose what happened to them. We also have the ability, based on the reports that we receive, even if the child has made no disclosure, but the facts that we know contained in that report indicate that we should be concerned for sexual assault and abuse, that child can come in for an interview. Many times, especially with the young kids, they really are not able to, at a developmental stage where they're able to talk about what happened, because they often don't have a sense of time, place, and when the sequence of events. And they may be reluctant to tell because many of these cases involve somebody in their family or somebody close to their family, somebody that they know, and they're afraid to get that person in trouble. They're afraid of what might happen to them if it's decided that their home setting is no longer safe. The nature of child sexual abuse often does not leave physical indicators or evidence, and very often, even with a penetrative event where there has been, one part of the body inserted into the other, children's tissues heal very, very rapidly. So we often see no injury, and we see an exam that is termed normal. And it really is normal to be normal when a child has been sexually abused. It's up to the PDSANE also to really use a lot of critical thinking and clinical judgment to determine a plan that has a child's best interest at the focus of it. Again, we want to make sure that we put that child in a place where they realize that their body is healthy and that they're on the path to having a normal, healthy life. Next slide, please. In addition, at the CACs, within the past 5 to 6 years, there was an amendment to Chapter 119, which is the law that governs what DCF, the Department of Children and Families, what sort of cases they see. You know, there's physical abuse, sexual abuse, neglect, and about 6 years ago, the commercial sexual exploitation of children was added to that mandatory reporting requirement. And so anytime DCF receives a report that indicates that a youth 17 and younger may be the subject of commercial exploitation or human trafficking for sexual purposes, those reports will absolutely be screened in and sent to the district attorney's office as well as to the CAC. And the filing you don't have to have full out evidence, all the facts that you need. You really have to there must just be a concern that the minor is being exploited or, based on the circumstances, at risk of being exploited. In addition, when we work with these youth, and many times the SANEs that respond to the emergency departments may be called in to see these youth, it's really important for us to be able to explain to them the limits of confidentiality. That is that we will be filing a report, and the report, we need to make sure that it's robust enough for anything going forward, but we also need them to understand that these reports will go to the police, the report will probably go to the DA's office, and if there's concern about their parents finding out, we have to let them know that that is going to happen, and we can work with the youth to be able to really carefully craft what we say so that they do have some say in it. Often when those referrals go to the CAC, to their CSEC coordinator, the youth is not interested at all in coming in for a forensic interview, but may be willing to see what the CAC looks like, to come on site, to meet the members of the team, and to talk confidentially with the PDSANE about any health concerns that they have. Next slide, please. So in fiscal year 2019, we saw PDSANEs, we counted their exams as well as the forensic interviews that they participated in. And this kind of gives a breakdown for the counties that we're in presently. In the very near future, we are going to be expanding our services into Franklin, North Quabbin, and the Hampshire counties as well. Thank you. Next slide. As Christy mentioned in her portion of the presentation, we do operate under a principle of do no harm. We don't want to re-traumatize the child, and that begins with not making sure they only have to tell what happened to them one time and one time only. So we provide the level of care that's appropriate for the concern for sexual abuse. We also provide the appropriate level of care for the child's developmental stage. We don't interview the child. However, if the child makes a spontaneous statement while they are with the PD SANE, we would include that in our medical record using a quote of the exact words that the child used. We do not do invasive procedures at all. Any testing that we do for sexually transmitted infections is done with a urine sample. And if the child would need serology, we would send a recommendation to a lab to have that done if it's needed. But very often that isn't needed. We also, with the exam, anything that we would be doing would be by the use of swabs, and nothing is ever inserted into the child, if it's a female child, into the child's vagina. If the child is unable to participate at any time, they know that they just have to raise their hand and the exam stops. And the most important thing is to support the child and to let them know that they are healthy. Next slide, please. So the Massachusetts SANE program was developed one of the first pediatric evidence collection kits in the country, and within a few years after that, Alaska came along and did a kind of a replica of the PD kit. The outside of the kit is cute and friendly, but the inside contains all the different steps that need to be done. Next slide, please. We can also use the PD kit for children older than 11 if in the practitioner's clinical judgment or an assessment of the child's developmental stage, that it would be more appropriate to do a PD kit, which has a little bit fewer steps than the adult adolescent kit. We provide the emergency department clinicians with a lot of guidance regarding the timing, when to collect evidence, as Christy mentioned earlier. If it's an acute case, it's within 72 hours or 3 days. We also advocate for do no harm principles, make sure that they understand their obligation to submit a mandated report. And these questions, the questions that people have about indicators are never black and white. They're often very into kind of a gray setting. So we are always available. And this is talking about the regional coordinators, the associate directors, the PD SANEs. We're always available for questions and for some guidance when things don't appear to be clear. And next slide. So as I said, the goal of the CAC is to provide a coordinated response to disclosures or concerns for child sexual abuse in a setting that really is child-friendly and reduces the risk for re-traumatization. The Children's Advocacy Centers in Massachusetts are all aligned under the Massachusetts Children's Alliance, which is the state chapter of the National Children's Alliance. And it, along with PD SANE, is involved in establishing and monitoring our best practice responses for kids and families. Next slide. As I mentioned, we are in 8 CACs right now with 2 more to come soon. And I think you can see by looking at them that they all are a little bit different. But at the same time, for instance, in the upper right-hand side of the screen is the inside of the medical suite in Essex County. That county's CAC is located within an office building, as is the one in Middlesex County. But each of these CACs has a dedicated health suite, which looks very much like the office of a pediatrician, your nurse practitioner, that would be anywhere in any other location, except it is really more appealing sometimes to the child. Next slide. So this is an example of what is inside our health suite at the Plymouth CAC in Brockton. You can see there's an exam table. We have all of the equipment that you'd normally find, you know, a scale, otoscope, ophthalmoscope, an exam table for the children. During COVID, we have replaced any cloth and linen sort of materials with paper supplies to increase safety for the patients. You'll see also that there is the PDSANEs use an electronic medical record, and their electronic medical record is tied to a magnified computer-driven colposcope, which will help them to be able to visualize more clearly the external genitalia of the children. And we do photo documentation of those images for every patient. Next slide. So with COVID-19, I already mentioned that we did end up spending a lot of time obtaining PPE for the PDSANEs for the families and children, and other disposable items for the health suite to minimize the amount of cleaning that would have to be done and to make it safer to be disposed of at the end of the day. We also began to do COVID screening for patients and families and staff at the CACs, if the CAC agreed to do that, in order to ensure that the children remained healthy, the families remained healthy, staff remained healthy, as did our PDSANEs. We crafted reopening guidelines that were required by the COVID Command Center. I think that was last April that we finished doing that addressed patient safety, staff safety, PPE, and infection control. We moved all of our staff meetings to a virtual platform, and to ensure that we were in close communication at all times. And the PDSANEs also did the majority of their screening on a virtual platform with the families to ensure that a building of trust from the very beginning. The CACs also transitioned to virtual platforms for forensic interviews, and they are still, to some extent, continuing along that path until we get further guidance. And next slide. It's now my honor to present Randy Petricone, the Associate Director for the TeleSANE Center.
Thank you, Catherine. So I'll be chatting with you all a little bit about TeleSANE in Massachusetts and how the Telenursing Center has allowed us to expand access to SANE expertise across the Commonwealth. Next slide, please. Okay, so these sort of headlines and articles might be from places other than Massachusetts, so other cities and states across the country. However, this is actually a problem that is right in our own backyard as well. So access to SANE care is really not equally available across the country as well as the Commonwealth. So before the Telenursing Center was developed, we were in about 50% of the hospitals that have emergency departments across the state providing in-person SANE care. So that adult adolescent response that Christy was talking about. Obviously, 50% is not enough. We're trying to get to 100% and want to make sure that everyone in the state has the same access to SANE expertise. So one of the things that allowed us to do this was a grant that Joan Sham and Cheryl Ray applied for back in 2012 with the Office for Victims of Crime. And they were awarded that grant, and they were able to establish a telenursing center, which I'm going to be talking to you about today, and then formalized our TeleSANE program that I'll also be speaking to you about. So next slide, please. So the vision of the National Telenursing Center, we really wanted to utilize telehealth technology to improve the sexual assault patient experience as well as the clinician experience. So we wanted to increase the quality of forensic evidence collection, but also support nurses that were doing this work that weren't formally trained or didn't have enough experience after formal training. So back in the day, in 2012, telehealth was a thing, but it was certainly not as booming as it is now. So some of this may seem like a no-brainer at this point, because since COVID, telehealth is booming. But this was a novel idea. In fact, the telenursing center developed by the Massachusetts SANE program was actually the first telenursing center and the first TeleSANE program for adult adolescent patients, so that 12 and up age population. So we were kind of charged with providing support and guidance to clinicians who were caring for these patients in underserved communities or settings that had low volume. One of the things that was really important to us was to integrate local rape crisis and advocacy response. So that is what we did. When we started looking at sites, we wanted to make sure that when a TeleSANE responded virtually over that video conferencing technology, that an advocate would be responding as well to the hospital physically to be there to support the patient. Next slide, please. So first we had to establish a center. So we decided on having a brick and mortar center to take care of our patients remotely. There are 2 private session rooms. You can see both of them here. So they do have 2 computers in each room. One is strictly for the TeleSANE exams, and the other one is for admin work. The nurses may have to check their email or something like that, and that's done on a separate computer. So I think sort of the take home about these spaces are that they are private and secure, so they are locked at all times. We have acoustic sound dampening panels on the walls to help sort of dampen the sound a little bit. One of the great things about this space is that it's located at Newton Wellesley Hospital in an administrative building. So it is far from sort of the buzz of the hospital, and it's not around patients. So we're sort of up in the top floor in a corner. It's really important for us to talk about that with patients when we get them on the screen. We want to make sure that they understand that we're in a private space. No one can hear what they're saying. We also talk to them a lot about kind of the specific technology. So next slide, please. So this is the technology. Again, it may not be that exciting, as most of you are familiar with telehealth as well as video conferencing technology at this point, thanks to COVID. But this is essentially what the technology is that we use. So at the center, we have a desktop computer with a speaker microphone, as well as a mounted camera. We don't use the camera that's built into the computer. And then at the hospital end, we have that cart that you see there on the left. So we have a pan tilt zoom camera mounted on the monitor. So it's essentially a computer there on the cart. And then we also have a speaker microphone built in. We have found that this technology has worked really well for patients. Essentially, we use Zoom for healthcare. So it's HIPAA compliant. It's a highly encrypted, secure software. And, you know, it's really easy. You're all on Zoom now. You know that Zoom is really easy. So it's, you know, it's quick, it's easy to log in. It's not difficult to troubleshoot if the camera's not working or people can't hear you. So it's worked really well for us for years. And so It's really simple, easy to use, and as you know, technology can be really scary sometimes. So this helps when we're training those emergency department clinicians to kind of get on board and feel comfortable with having this big cart in their exam room when they're taking care of patients. Next slide, please. So the telenursing center model. Obviously, it's trauma informed. We've talked a lot about that today, but it's patient centered as well. And we really try to accommodate, the patient's needs and give them options whenever we can. So we're there 24/7. The SANEs that are experts in our program are actually the SANEs that we train as TeleSANE. So they receive some additional training to become TeleSANEs. And that just means that the role is slightly different. There's more teaching involved, and there's that remote aspect. There's the, being comfortable with technology and troubleshooting things in the moment, and sort of being flexible when technology doesn't work perfectly. And so we train them. And it's kind of nice because we have some built-in quality control. So we have the experts in our program that are traveling to the center, and that we sort of know how they work when they're taking care of patients in person. And so we know what we have to offer those remote hospitals that we're working with. One of the things that we always want to make sure everyone knows is that we are tailoring our care to the patient, the individual patient. We want to make sure that we're addressing their needs. But equally important to us is actually taking care of that ED clinician on the other end. So they may have little to no experience taking care of these patients, and they might feel really, really anxious. And so it's important for us to help work with them kind of upfront outside of the patient's space. And we've built our model to do that. So we have sort of this huddle pre-conference, if you will, with the patient, with the nurse, sorry, not the patient, with that ED clinician about the patient's care. So we can kind of see what they're worried about and how we're going to plan to care for this patient. And then, which is lovely and illustrated in this graphic here, this is kind of when we're all in the room together. So you have the nurse with the clipboard, you have the TeleSANE on the screen, you have the patient in the bed there, and then you have the medical advocate from the local rape crisis center there by the bedside. So this is what it's like in the room, and it's really nice that the TeleSANE kind of has this bird's eye view of what's happening and can focus on all of the things at once and sort of monitor the space from afar, but also really feel like they're there in that room. We also wanted to make sure that these nurses that we were working with, as well as the providers in these emergency departments, had some training. So we do train them up front on sort of the basics of the kit, how to engage with advocacy when they're there, but also things like swabbing techniques and mandatory reporting and the like. So we want to make sure that we're all on the same page when we're in there taking care of the patient. And then after the patient's discharged, we again meet with the nurse to go over any specifics regarding the paperwork, to package up that kit, maintain chain of custody, just as Christy was talking about earlier. So next slide, please. Patient acceptance rate. So I feel like this is something that often comes up when we're discussing TeleSANE. Maybe in the future, with all of the increased frequency of telehealth use since COVID, it will be less. But this is a very long exam. It can be a very invasive exam. So it's a reasonable question. Part of what we want everyone to understand is that it really has to do with the messaging first. So this is actually a great quote. The nurse simply tells the patient that they have a partner who participates and advises them, and that they are the experts, and we've found to have better results when we use the experts. I think that's something that we always want to get across is that you're gaining access to this expertise during this exam, and that's why the TeleSANE is here. It's very important for us that the patient knows that we are not recording anything over the equipment, that we reassure them that they're, we're in this private space. What they say to us is confidential. We don't do any of the paperwork. We're just guiding the nurse on the other end to do the paperwork. So sort of all of that stuff that we've built in our model and in our practice is really to be trauma informed. So we want to be flexible. We want to make sure the patient knows they're in control. They control the pace of the exam, that they can accept and that they can decline the service, and that they can decline at any time. You see that our patient acceptance rate is 94%. And so we're really happy with that. Patients do readily accept this service. The declination rate of 6%, I just want to note that that's actually sometimes the patient declining evidence collection altogether. It's not simply declining the TeleSANE assistance with evidence collection. They may just be going to the emergency department for medical care. Next slide, please. Patient receptivity. So when we had our grant-funded pilot project, evaluation was built in. We wanted to make sure that the clinicians we were working with and the patients that we were taking care of with those clinicians felt like TeleSANE was something that was reasonable, desirable, helpful, efficacious, all of those things. And so quotes like this really hammer home that this is something that we can and should be offering to patients when in-person SANE is not available. So like I said, one of those things that we do is give back control whenever we can and offer the patient options. So sometimes we'll have the camera not on if they don't want that on and they don't want to be seen. Other times we'll just turn the camera away from them and just focus on the evidence and the clinician that we're working with. So if they feel like they need that extra layer of privacy, this quote's really great because we sort of thought that things like the pelvic exam would be something that the patient wouldn't want us to be on screen for, and they wouldn't want to be on screen for. And so this patient, at that time when we offered, said, "Oh no, you should stay. You seem to have a lot of good ideas." And that was to the TeleSANE. And I think that was a real wow moment for everyone when we were in the pilot phase. I think that, now, this is not something we routinely offer, although we do routinely offer kind of having the camera off of the patient if that's something that we prefer or that they prefer. Next slide, please. So we also interacted with a lot of clinicians and wanted to get feedback from them. So you can see there that it says clinicians in corpsmen. Corpsmen are essentially just the clinicians in the ED with the Navy sites that we worked with during the pilot project. So this scale goes from -3 to +3, and the impact of the telenursing experience was very positive. It's very clear here that clinicians, when they worked with us, they felt like that, they had confidence in their ability to provide the patient with an effective exam and the best care, and they felt supported by us. Next slide, please. Here we have another quote. I'm not going to read it word for word, but you can see that, supporting those nurses is really important to us, and it's really important to them. This is something that is incredibly anxiety provoking. I remember being a brand new grad, a new nurse in the emergency department, and being handed the box, this kit, and being told, to go in the room and basically don't come out for 4 hours and read the instruction booklet. And so I had little experience and no SANE expertise at that time. And I was incredibly nervous. And, it would have been great to have a TeleSANE on the other end that I could have called, even for a chat on the phone, even if the equipment didn't exist back then. It would have been really nice. So we're trying to help these nurses obtain, high quality evidence for these patients, but we also want to make sure that we're there to support them, and we help them after cases if they feel like they need to talk more about the exam they just did, or whatever else they might need from us in addition to like actually completing the box. Next slide, please. So part of the pilot project was to work with 2 Massachusetts sites. So we have been working with Metro West Medical Center and St. Anne's Hospital in Fall River since 2016. After we had our evaluation report, when the grant ended in December of 2018, we saw this as a viable option to expand in Massachusetts. So we were armed with our evaluation report that said that this is something we can and should be offering patients in the Commonwealth. So we started to work on our expansion. This was a competitive process, and the hospitals that you see here, Athol Hospital, Bay State Franklin Medical Center, Beverly Hospital, Good Samaritan, North Shore Medical Center, Sturdy, and the 2 island hospitals, the Vineyard and Nantucket. They were selected, for a variety of reasons. It could be patient volume, it could be patient access, geographical location, needs, community needs, those sorts of things. And so here's what the program looks like right now. You have 10 sites. We're not sure what the future holds. I think that there's always possibility for more sites in the future. We really would like to see what it looks like in terms of patient volume, having all 10 sites up for a year outside of COVID. So we have a little bit to go before we can determine if future expansion is something that we can do. Next slide, please. So the NTC impact. We have been called for 474 patients. 316 of those patients have been Massachusetts patients. We have completed 294 patient encounters or full exams. So a medical forensic exam where evidence is collected. About, I would say 200 of those have been patients in Massachusetts, and then 180 patient consults, 120 of which patients have been from Massachusetts. Patient consults can be anything from perhaps the patient's outside the 120-hour, 5-day window, and they have some questions about medical care and what sorts of prophylaxis can be offered. It may actually be a patient who's under the age of 12 and they're trying to find out what the local children's advocacy center might be, or how they can get an exam for a pediatric patient, those sorts of things. We also do a lot of trainings. So a lot of trainings for the hospitals that we work with, but also lots of trainings to help people understand what TeleSANE is, how the process works, how we engage with hospitals and take care of patients and support clinicians. We also often get the question about testifying. So who testifies in court? That is still yet to be seen. They did have a rapid DNA process at one of our sites in California, and we had 2 CODIS hits from swabs that were collected with the nurses that worked with the TeleSANEs. And so we did have 2 guilty pleas come out of that, but in Massachusetts, we've only been seeing patients since 2016, and we have not been subpoenaed yet at this point. So that remains to be seen. Next slide, please. So COVID-19 innovation. If you can all remember, I'm sure you all remember too well, what things were like over a year ago. People had to be worried about PPE availability, Staffing was impacted significantly oftentimes, with people having to self-isolate or quarantine due to exposure or awaiting test results. We didn't have these like very quick testing results that we have now. We didn't know much about COVID. We were worried about another surge. There was concern that we might not be able to get into hospitals at all. Maybe they wouldn't have PPE for us. Maybe we wouldn't have the staff that would be able to get there. And so sort of, creatively came up with an idea to convert one of our in-person regions, so the Central Mass region that has 5 hospitals, into TeleSANE, and to see how quickly we could do that and if it would be feasible for all the regions, should we need to do that, depending on, how bad the pandemic got. So one of the things that we did was sort of look at our current practice model and figure out how we could adjust that if we were going to respond to these hospitals in Central Mass. We decided to have our core DPH staff TeleSANE, so people like Christy Holden, people who are regional coordinators, so the managers of SANEs essentially. Those folks who have secure offices work as the TeleSANEs remotely during the 7-week pilot. So 7 weeks, 5 hospitals, we ended up seeing 21 patients. I know Christy mentioned how the volume was down everywhere, but for some reason, the Central Mass volume really seemed to pick up when we started this pilot. So the nurses were working from home, the TeleSANEs were working from home. They had iPads, so they didn't have that fancy setup that we have at the center at Newton Wellesley. And then also the remote hospitals didn't have that fancy setup with the cart, but they did have, a Zoom loaded iPad as well, highly secure. There were basically no other functions that either the TeleSANE or the ED clinician could do. It was basically just Zoom and that's it, to make sure that it was incredibly secure. One of the things that we came up with, I know I mentioned before that the TeleSANEs don't do any of the paperwork, but we did do some of the paperwork for those nurses, partly because we didn't do that upfront training like we do with our ED clinicians in our regular TeleSANE model, but also to reduce the risk for the patient and the nurse. So to kind of limit exposure, they weren't in the room together for a long period of time, and the nurse came in strictly for the evidence collection portion. The other thing that we did was, to make sure that we evaluated this process as well. So everything that we're doing that's new and innovative, we always want to make sure that we're looking into, is this good for patients? Is this good for clinicians? One of the things that we were reassured by was the technology. So the technology and the equipment that we're using, particularly on the hospital end, it's really important to have that fancy, big, bulky cart, because it does give us a better view of everything that's happening in the room. We also learned that potentially, having some satellite sites or even working from home, having people in their secure home offices doing this work could lend itself to an immediate response. So it was really great during COVID times because we responded immediately. We freed up that patient to get out of the ED quickly, and they didn't have to wait for a SANE nurse to arrive because it was immediate response. But also it freed up the room so that someone, maybe, acutely suffering from COVID would get that exam room and that patient could go home more quickly. So it's something to think about. It definitely allows us a more rapid response. And I think that's pretty much it. It reassured us that a lot of the things that we're doing already are working really well. And it gave us some potential things to think about in the future. Next slide, please. So for more information, you can contact us at the MA SANE Program, massane@mass.gov. And if you have, questions specific to TeleSANE or the adults adolescent in-person response or PDSANE, whoever is checking that email regularly will make sure that it's routed to one of us. Next slide, please. So I think that it's always important when having a presentation like this to just remind everyone that you really should believe everyone that comes to you reporting or disclosing a sexual assault. You want to encourage them to go to the nearest SANE emergency department for medical care and evidence collection. Of course, that can only be done within 120 hours or 5 days, so it's something to keep in the back of your mind. You can offer to call police if they would like to report. If they are in that evidence collection window, it is best to encourage them not to shower or change prior to going to the ED. If they have, though, that doesn't matter. We can collect evidence days out and after lots of showers. So you should never discourage anyone if they do disclose and say like, oh, I've taken a shower, I've had lots of food and drink, and I've washed my hair and all those things. Still encourage them to come and see us and get the care that they deserve. And then you can also offer local rape crisis information. I do believe we included that in our handouts, but we have a list of all the rape crisis centers and which hospital they're or which county they're affiliated with. Next slide, please. So we want to thank you for joining us. We are always trying to bring compassionate care to sexual assault survivors, and we are open for questions. I see Christy's back on, eager to answer questions. Catherine, great.
Just as a reminder to everyone, if you have any questions, please use that Q&A function down at the bottom of the screen. Don't be shy. Looks like we did get a couple of questions. One being, what differences did you see not having in-person RCC advocates during COVID?
I'll answer that because I did do a couple of a bunch of cases during COVID without the advocates. And some with, there's one rape crisis center, a New Day, who very quickly came back to in-person. But it's very different because they're not in the room. When we call the hospital, we ask the staff to notify rape crisis. So we want them to come to the hospital. We want them to be given a phone. We like to make it, kind of not an option for the patient, but if they're there, they can poke their head in and offer their services. I think 99.9% of the time that when the advocate's there, the patient wants them in the room. But it just was very different. Like one of the hospitals tried to have an iPad with the rape crisis center, but the connection wasn't working. It wasn't, so it was different not having them in person. So I am very much looking forward to them coming back in person. It's just helpful. We work as a team and we don't do our work the best without them, I think. So anyone else want to add to that? I know, Randy, you probably did the same.
Yeah, absolutely. If it wasn't clear from our presentation, we really adore having the medical advocates in the room with us. They're on our graphic for TeleSANE. So we sort of expect or, anticipate that they're going to be in the room for all of those patient encounters. So we're excited to have them all back, hopefully soon.
Thank you. We had a question come into the chat function. Someone said, I like the tracker idea. I think it's amazing for them to be able to track their rape kits, but what about the ones who had rape kits before that was put into place? Can they track theirs or no?
No, there's no way to track those kits. I think you saw on the picture that I put up, there was a barcode, and the barcode's numbers were like put into the system. So when they first started this, there was kits in the hospital. So they had what's like retrofitted envelopes that we took and put on the kits, or not we, but the hospitals took and put on the kits and enter those numbers into the track kit system. So there's really no way to go back. So we're just moving forward with this, and all the cases that are done now have retrofitted numbers, or if they're brand new kits, they have the track kit barcode right on them now. So
are there any plans to expand services to Western Mass or anywhere in Hampden County?
anyone want to take that? Go ahead, Randy.
So we did, if you want to pull up the map, you're gonna have to go back a lot, Christy, though, for that. But it's a nice visual. The 2 TeleSANE sites that we added out of the new sites, 2 of them are in Franklin County, which is not Hampden County, but it's definitely, we're working our way west more with TeleSANE to try to fill in some of those holes. So we have Athol Hospital and we have Bay State Franklin Medical Center. We do have Bay State Medical Center as an in-person SANE site, but Holyoke Hospital is on our radar as all hospitals not currently receiving services. So I had mentioned that we were in 50% of the hospitals with emergency departments prior to developing the telenursing center. Currently, with our Mass TeleSANE program expansion, we're in 63% of hospitals with emergency departments. So we still have a ways to go to get to 100%, but we are working on it.
And that's our goal.
That's great. Thank you. Another question, what additional training do pediatric SANEs receive, or educational backgrounds and qualifications do they have in addition to being RNs?
Okay, so back when the first training was done, it was a group of people, and it was done in sort of a classroom and then clinical setting with a lot of didactic material. As the program, and in fact, we still have at least on staff, at least 3 of the PD SANEs were in that initial training course. What happened with the expansion was that we knew we needed to have practitioners who could practice independently. I know that sounds repetitive. So we require the PD SANEs to be nurse practitioners because they have more expertise in physical assessment, diagnosis, treatment. They can order lab testing. They can also write prescriptions and then make referrals. So in addition to being an RN, there needs to be then a graduate degree and certificate as a nurse practitioner. At this point in time, when the PD SANEs come on, when we bring on a new PD SANE, it is a sort of side-by-side, hand on the back, with you all the way training. Our trainer for PD SANE is Cynthia Moore. She is our clinical coordinator. And so she will work very, closely day to day with the new PD SANE. And that training takes anywhere from about 6 months to a year to complete, so that the PDSANE is familiar with trauma-informed care, the multidisciplinary team practice, performing external genital exams and photo documentation of those exams. And then they take a certification exam at the completion of that.
Great, thank you. Another question about PD patients. Oh, no, never mind. That was just a comment. For PDSANE, what happens when a child does not want to participate in a forensic interview?
The interview, you know, there would be, I think the interviewer would try to build trust and rapport, but if the child really is unable to do it, there would be no interview. I would hope too, if there was a concern, and I think this would be is the practice, if there was a concern, without a disclosure, that the child would be offered the opportunity to meet with the PDSANE.
Thank you. And we have a couple of questions around language barriers. The first one being, how do you manage language barriers? And then another one to piggyback off of that. How many SANE staff members speak languages other than English? And are these staff members available across communities in the Commonwealth?
All right, I'll take a stab at that. We do have a couple SANEs that we just, they basically have to do like a language certification, but they're not in every region. And I'm not even sure of the total number that we have. And I know that those nurses speak Spanish. So if they have that certification that we've signed off for them, that they are fluent in Spanish, then they can be in the room with the patient by themselves and do all of the interpretation. We'll use the hospital interpreter. So what we would like, you know, best case scenarios is having a person in the room behind the curtain, but a lot of places now have either the phones or the iPads that are on wheels that we're using to interpret. So not the best case scenario, but we obviously don't want to use any family members. We don't want to use, we use the hospital-based interpreters, so.
Right, and for PD, we work with a company called Cross Cultural Communications that I believe is located in Woburn. It provides both in-person and phone interpretation. Again, we really prefer to use the in-person. And they're fabulous, and we will and cover a plethora of languages across this Commonwealth. And in the event that a child and a family is unable, or they're unable to afford any kind of service, you know, for instance, if we have lab testing that we've ordered, it's really important to know that we work with the CAC to be able to absorb that cost for the family. But the SANE program does use this interpreter service, and we have a contract with them, so we pay for that.
Mm-hmm.
That's great, thank you. I will do one last call for questions. I'm not seeing anything else in the Q&A function. I will take this opportunity to let all of you know that we will be distributing a couple of resources in addition to the slides after this training. We also were recording this, so we will distribute the recording to you all as well. And we're getting a lot of thank yous in the chat, but no more questions that I'm seeing.
Great.
All right. We might be letting you all go a few minutes early. Thank you to Christy and Randy and Catherine. This was fantastic. We're really grateful that you were all able to join us today. And thank you to everyone who was in attendance. I hope you all have a really great day.
You too. Thank you so much for having us. Bye-bye.
Thank you.
Bye.
Bye-bye.